Hello, everyone. My name is Tom, and I'm a postdoc with Evidence Synthesis Ireland. So we're delighted to welcome you to this exciting webinar on integrating stakeholder-informed evidence into core outcome set development, a case analysis of methods. So just a brief intro for those of you who mightn't know much about us. Evidence Synthesis Ireland, which includes Cochrane Ireland, is an all-Ireland initiative funded by the Health Research Board and the Research and Development Division of the Public Health Agency in Northern Ireland. And our aim is to build evidence synthesis knowledge, awareness and capacity on the island of Ireland. So we have a number of key activities for achieving that aim, and one of them is our monthly webinars on an evidence synthesis topic. So our presenter today is Dr. Ginny Brunton. Ginny is an associate professor in nursing at Ontario Tech University in Oshawa, Canada, with 25 years experience as a research methodologist, focused on evidence synthesis with colleagues at the EPPI Centre, London, and McMaster University in Hamilton, Canada. These methods have focused on quantitative and qualitative research on the public's views of their health and care, funded by Department of Health and Social Care, the ESRC, the NIHR, and CIHR. These research synthesis methods include the use of framework synthesis and qualitative comparative analysis. Dr. Brunton's work arises from an interest in communities and involvement in health intervention development, implementation, and evaluation. She has conducted systematic reviews of community engagement in health promotion, most currently to inform NICE guidance updating. She has also studied issues in maternal infant health. Ginny is on the line now, but before I hand over to her, I'll just provide a bit of background on the topic. So research trials in health and social care must be robust enough to be relevant and accessible by stakeholders, which includes patients, the practitioners, the researchers, policymakers, and the funders. The core outcome sets allow the development of stakeholder-agreed key outcomes to use in future trials and further build an evidence base through inclusion in future meta-analysis. Core outcome set development arises from consideration of a scoping review of trials and a primary qualitative study of stakeholder views by a transdisciplinary and core outcome set advisory group. However, primary qualitative research can be time-consuming with unclear impact. This webinar will outline recent innovation in core outcome set methods that explore the potential added value of a qualitative systematic review of stakeholder perspectives alongside a systematic review of trial outcomes to inform core outcome set development in neonatal care using case analysis methods. Using these methods together, identified more outcome domains for our core outcome set group consideration and depth of understanding. So before we start, we will have time for questions at the end, and we do encourage you to type your questions in the question and answer section at the bottom as we go along. And hopefully you should be able to upvote these questions as well. We'll be making a recording of the presentation available on our website, and we do encourage you to sign up to our newsletter also. So that's all from me. I will now hand over to Jenny. So thank you all so much.
Great. Thanks for that introduction, Tom. That's very kind. And thank you for your invitation to present today on this work that I did a few years ago now with colleagues from Imperial College London. So as Tom said, we're going to talk about ways to use qualitative evidence synthesis or systematic reviews of qualitative research, kind of beyond what you would normally use a qualitative evidence synthesis for. And I should start by giving you a little bit of background from me. Hello from Canada. I'm in Oshawa, which is just a little bit east of Toronto on Lake Ontario. And I'm also saying hello from the UK because I worked for many years at University College London at the Epicenter Social Science Research Unit project of colleagues who did health policy research. So originally, I started getting into research through my role as a public health nurse in Hamilton, at the city of Hamilton. And I was working with colleagues from the School of Nursing and the Department for Epidemiology and Biostatistics at McMaster University. We were looking at producing systematic reviews of public health nursing interventions. And that kind of morphed into looking at the effectiveness of public health interventions. to inform policy and practice. And so that was kind of my foray into doing research, and also into learning about systematic reviews. And that led all kinds of interesting places. It led me into a master's in health research methodology at McMaster. And that kind of led to, I wonder if I can get this next. There we go. That led to meeting and getting to know colleagues at the Institute of Education at University College London at the Epicenter, where I moved in 2000 and worked there for 19 years, actually, until I came back to Canada in 2019. And so at the Epicenter, we were doing a Department of Health funded program of work, so Department of Health for England. They funded a program of work, which is still ongoing. It's been going on for about 23 years now, that they commission us to do systematic reviews of public health and health promotion policy. And they came to us with really tricky and interesting issues around, how do you reduce the teenage pregnancy rate in England, for example? Or how do you encourage walking and cycling amongst young people? So they were coming to us with kind of policy-driven needs, and we would synthesize the research around the effectiveness of various interventions. But we also combined that with qualitative research on participants' views or experiences or perspectives of the phenomenon that we were examining. So, for example, with teenage pregnancy, we might be doing a meta-analysis where we were looking at the effectiveness of interventions to reduce teenage pregnancy, but at the same time, we were also looking at qualitative research on teenagers' perspectives of the barriers and facilitators to pregnancy prevention. And so we developed methods to try and put all of that research together and in such a way that we could provide some recommendations on what works, but also a bit about how it works and why it works to help inform health policy decisions that were being made in the UK. So as I say, I did that for 19 years in the UK, and then most recently came back to Canada and took up a position as an associate professor in nursing at Ontario Tech University. And here I focus on teaching in public health and community health, but also I'm looking at research in maternal health policy and stakeholder engagement. So the ways that you can involve different stakeholders, so that could be policymakers, healthcare professionals, and members of the public in systematic reviews and knowledge translation. My clinical background is nursing, obviously. I also trained as a midwife and worked for some years in the UK as a midwife. So hence the interest in maternity health policy. Okay, so this presentation, what we're aiming to do is to outline a recent innovation in core outcome set methods that explored the potential added value of using a qualitative systematic review of stakeholder perspectives alongside a systematic review of trial outcomes to inform core outcome set development in neonatal care using case analysis methods. For this presentation, what we're going to do is talk a little bit about core outcome sets, about what they are, why we use them, and what the process is. And then I'll talk a little bit about our innovation, how we tweaked that process, and the lessons that we learned from it. And then a little bit about where we might go next with the method. So core outcome sets are sets of agreed or core outcomes that can be used across trials in a clinical field. So, as many of you in the audience are probably trials methodologists, you know that there are lots of different ways to measure any one outcome. And that can be complicated when you're trying to draw those trials together into a meta-analysis and understand effect sizes. And so in many areas of healthcare, there are moves to try and develop core or agreed outcomes that could be used across trials so that we could more easily combine that research evidence. And the reason we do that is that bringing together the findings from multiple trials can strengthen research by adding power to the conclusions that can be drawn from individual trials. And that can improve evidence-informed decision-making. And the COMET initiative, of course, is an organization of professionals who've come together, researchers and professionals and members of the public who've come together to try and develop robust methods for core outcome set development. They're needed because this idea of doing systematic reviews to pull in the findings from multiple trials on a particular topic. Systematic reviews will give us a more comprehensive and robust answer about effectiveness. However, trials evaluating the same interventions rarely measure or report identical outcomes. So as I say, there's multiple ways to measure any one outcome, and that can lead to problems when you're trying to pull that research together further on down the road. So this limits the ability to combine the results from multiple trials in systematic reviews and meta-analyses. The core outcome set development process so as I mentioned, the COMET initiative works to develop methods of determining core outcomes in different health fields. And there's a recommended set of processes that most people follow when they're doing the COS process. So first, they determine the scope and the context and the setting of trials, then identify a comprehensive inventory of relevant outcome domains, and then utilize this inventory to reach a consensus amongst multiple stakeholders about which outcome domains are most important. So this idea of kind of pulling all the trials together on a topic and then looking to see what outcomes were used in those trials and then taking those outcomes into a consensus development meeting. Usually that's identified through doing a systematic review of trials to establish all the outcomes. And then on top of that, they will do some primary qualitative research with key stakeholders. So when you set up a core outcome set process, you establish an advisory group, and you will have consensus development discussions with that group. And you bring the findings of that systematic review of trials saying, these are all of the outcomes. And you also do some primary qualitative research like focus groups or interviews with key stakeholders. So that could be policymakers, healthcare professionals, members of the public, former patients or clients that have experience of that condition, and ask them what are the important outcomes that they think should be routinely collected across trials. And you bring all of that into the consensus development process for core outcome set development. So obviously, patient and public engagement is key to determining relevant outcome domains. The trials will give a certain perspective, but you also need that perspective from patients or members of the public, caregivers, for example, about what's important, what should be measured in trials. So if patient and public engagement is key to determining relevant outcome domains, the problem is that doing primary qualitative research is often very time consuming, and it's costly, and it's not always fully representative. For example, if you're not able to identify all of the key stakeholders. And so it's a very tricky process to try and organize within core outcome set development. And of course, with core outcome set development, we were looking at trials in neonatology. And in neonatology, there's a wide range of outcomes similar to other healthcare areas. Synthesis of these trials can be difficult, if not impossible, and certainly at risk of bias. So there was a need to have a look within neonatology, specifically around NICU care, neonatal intensive care unit care, and understand how the trials that take place in NICUs could have a set of core outcomes that could be utilized in future trials. And so Professor Chris Gale at Imperial College London had an NIHR funded fellowship, which was a 5-year program of research, which I think is just about winding up now. And so part of that fellowship was to look at core outcome set development in NICU trials for neonatal care. And so this is, as I mentioned, this is care that's provided in neonatal intensive care units for babies who are in neonatal intensive care units. And that's a picture of our team. So myself, Chris Gale is behind me, and then Schwab Ali and James Webb. So we worked on the quantitative and the qualitative reviews that took place under this core outcome set development. So we've got this issue where trials that are related to neonatal care in NICUs report lots and lots of different outcomes. And it's really hard to try and gather the learning together from all of those trials in meta-analysis because they report different outcomes. And on top of that, if we're going to do core outcome set development, we need to do some kind of qualitative research with key stakeholders to understand what the issues are. But that's expensive, costly, it's time consuming. And so what we thought we'd do is try to add value to the consensus development process by conducting a synthesis of multiple qualitative studies alongside that quantitative review of outcomes. Okay, so rather than doing the qualitative primary study, we thought, okay, we're going to look at all qualitative studies that we can find on stakeholders' perspectives of neonatal care, NICU care, okay? And there's a little asterisk about beside multiple qualitative studies, because the important thing to remember here in this process is that we were doing a qualitative review to inform consensus development discussions, okay? So what we were trying to do was come up with a list of key outcomes that the Consensus Development Committee, the advisory group committee, could then discuss about which were important and which weren't important, okay? So a little bit about qualitative research. For those of you that are trialists, you might not be familiar with qualitative research, what it is, what it can do. It's a shorthand, okay? Qualitative research is a shorthand for empirical research that seeks the views and perspectives, opinions, attitudes, experiences of participants. So it's basically qualitative research that's getting at the views of different types of participants. And those participants can be patients, clients, caregivers, healthcare professionals, managers, policymakers, funders, whoever you like. Qualitative research seeks to provide more in-depth understanding of the social world that those participants experience. So going beyond whether something works or doesn't work to try and understand a bit more about what that experience is for people, perhaps why an intervention works or why it doesn't work. Generally, qualitative research provides detailed, rich, and complex data. It's often textual or narrative in nature, but it can be numeric as well. And within the consensus process, using qualitative research can add context on the why and how. So demonstrating the impact of a quantitatively derived health outcome. For example, a gastrointestinal outcome, looking at that within qualitative research might be something around feeding issues that are identified by a neonatal patient's mother. So we did 2 reviews. We did a quantitative systematic review and we did a qualitative systematic review, okay? And so I'm going to refer to them as the quantitative review and the qualitative review. For the quantitative review, it's pretty standard. We searched for electronic sources of research, Medline, Embase, Sinol, and Central. In order to be included in our review, it had to be an RCT or a cluster RCT. It had to be focused on infants requiring neonatal care in a high-income setting. There needed to be over 100 infants in each trial arm. And that was partly a pragmatic criterion, but also to ensure that we had the widest number of outcomes, because larger trials will tend to use more outcomes. So we thought we would still get representation by larger trials. We were looking for research that had been published within the past 5 years, so since 2012, and research that was available in English or was translatable. Now, when we identified our included studies, they were quality assessed using the Haddad risk of bias tool, and data extraction was performed on those studies using a previously identified framework of neonatal outcomes that was ordered by biological health systems that was developed by the NHS. And so that was kind of a framework of biological health systems, gastrointestinal, neurological, and so on. And in terms of quality assurance, the screening and quality assessment and data extraction, at each of those stages, we had 3 reviewers who reviewed a subset of studies until they reached a high agreement calculated by Cohen's kappa. And then a single reviewer completed those. Any disagreements or queries about screening or quality assessment or data extraction was resolved by a 3rd reviewer. For the scoping review of qualitative research, we searched more widely because it can be challenging to find qualitative research in electronic data sets like Medline and Embase. So you generally have to look further. So we looked more widely to allied health professional literature, to PsycInfo, ASIA, Sinol, and then we did citation checking and we did a Google Scholar search to try and locate qualitative research on perspectives of neonatal care in NICU. So in order to be included in the qualitative review, studies had to be peer-reviewed journal articles or funders reports. They had to be a primary study of parents, clinicians, or ex-patients' views of care. They had to be about NICU-based neonatal care, contain qualitative data, published within the last 20 years, and available in English or translatable. Now, critical appraisal wasn't performed on these, the included studies, because again, remember, the purpose of this review was to identify relevant outcomes for discussion and critical consideration by the Consensus Development Committee. So we didn't do critical appraisal. We extracted data using the same framework that was used in the quantitative review, so the biological health systems, and we used framework synthesis methods, meaning that any new outcomes or issues that were identified in the qualitative studies that weren't in the biological health framework, those new outcomes or issues were added into the framework. And so in terms of quality assurance of that process, again, screening, quality assessment, and data extraction, we had 3 reviewers who screened quality assessed data extracted a subset of studies. And then once we reached high agreement, a single reviewer completed the remainder of screening quality or data assessment, data extraction. And disagreements were resolved by a third reviewer as per the quantitative review. And we also conducted a 10% selection of random quality checks to just double check at each stage. So how did we put this information together from the quantitative review and the qualitative review? Apologies for the quality of this photo. It's not come up as well as I might have liked. But this is what Hong and Pluy would term a convergent mixed method synthesis. Okay, so this figure on the left shows you, the process of a quantitative review of neonatal trials, where we talk about searching, eligibility screening, data extraction, and analysis. And analysis for the quant review is really just descriptive frequencies of the different outcomes that were identified across the trials. And the qualitative review of stakeholder experiences of neonatal care, same, searching, eligibility screening, and data extraction, as I described in the previous slide. Analysis was to take the issues or themes that were identified in those qualitative studies, and they were thematically analyzed. And again, that process was done initially by, that process was done by 2 reviewers. And so we ended up with a list of outcomes or issues, outcome domains that were relevant to trials and to qualitative studies. And we brought those together, and then we interpreted the findings from those. So we took what would be considered a scientific, realist, critical perspective of this. And so this is the idea that reality is committed to, the mind-independent existence of the world investigated by the sciences, so that there is a reality out there that we can know, but it exists outside of all of our understanding. Philosophy 101, it's quite a shorthand. So this figure on the right is kind of a pictorial description of what we did. So the first stage, we were looking at quantitative review data and coding it into that biological health systems framework. And then we used that to help us code the qualitative review data, but with an added twist that as we identified new issues or information in the qualitative studies, we coded that and expanded the biological health systems framework. So it's a bit of theoretical development. The findings from the quantitative review, just to give you an idea of the number of studies that we were working with, as you can imagine, there were a lot of neonatal trials identified, initially over 24,000 through our searches. After duplicates were removed, we screened just over 11,000 titles and abstracts, and retrieved full text of just over 1,400 full text articles assessing for eligibility, and screened again on full text using the same criteria that we used at the title and abstract stage. We limited at that point to only looking at, when we did full text screening, we identified 978 trials and decided that we would need to limit the number of trials that we actually extracted outcomes from. So we limited to looking at trials that, only looking at trials that had over 100 babies in each arm. And that left us with 76 trials with more than 100 infants in each arm. And for the qualitative review, we identified just over 1,100 studies after removing duplicates, and then screening, we screened 1,038 records on title and abstract, excluded 900, and we were left with 111 assessed for eligibility at full text. When those were screened again using the same criteria as title and abstract screening, we were left with 62 included studies in the qualitative synthesis. So what did we get in terms of outcome domains? We found that overall, gastrointestinal outcomes appeared most frequently. So that might be, necrotizing enterocolitis. It might be, sorry, I'm drawing a bit of a blank. So gastrointestinal outcomes, survival was next most often reported across the studies in the quant review and the qual review. And so that was looking at things like mortality, obviously. Respiratory was the next most often reported, and so on. So you can see that there was a wide range of biological health systems where there were outcome domains reported, and that these appeared across both the quant and qual reviews. And there were 26 outcome domains, I should say. Yeah, 26 outcome domains identified across both reviews. So quite a lot of different outcome domains to focus on. In terms of how many from the quant review and how many from the qual review contributed to each one of those outcome domains, this graph represents that distribution. And so in terms of survival, so on the far left-hand side of this graphic, you've got survival. You can see that, 67 of the trials in the quant review measured survival in some way, and 14 of the studies in the qual review measured survival in some way. Within the quant review, there was 17 specific outcome domains that were focused on biological systems. And you can see them as the darker blue in this graph. And then the qual review is the lighter blue. The qual review identified 24 outcome domains, and these overlap obviously with the quant review, biological health systems, but they also focused on wider psychological and social issues, as you might imagine. So, for example, the gastrointestinal health system, the quant review identified trials where necrotizing enterocolitis was a particular outcome domain measured in so many studies. But the qualitative review demonstrated the meaning that was ascribed to that system, to the gastrointestinal system. And so that might be an example of a mom who was describing the neonatal care that her infant received and what her experience was of that time spent in NICU. And she would say that, she fully breastfed for 4 months, 100%, and she was very proud of that. And so that was interpreted to be within the gastrointestinal domain because she's talking about breastfeeding. For the quantitative studies, you might have blood pressure and pulse and desaturation events to indicate deterioration or improvement in an infant's condition. And so that would be classified under physiological stability, for example. But in qualitative studies, that might be interpreted as the NICU nurse's perception that an infant's physiological stability was dependent on external factors like NICU noise levels. So this suggests that outcomes might also be influenced by factors beyond the treatment under study, and that outcome domains should include assessment of wider factors beyond the infant's medical condition. So in terms of the consensus development process, this provides a lot richer information for the consensus development committee to discuss beyond the relevant outcomes. It's a bit more about why those outcomes are important, and helps them to think about how broadly applicable those outcomes are across neonatal trials. So both quantitative and qualitative reviews had unique outcome domains. Okay, so just doing the quantitative review on its own wouldn't have revealed all of the possible outcome domains that could be considered by a consensus development committee. And conversely, the same is true of the qualitative review. It identified outcome domains or issues that were unique to the qualitative review and that weren't found in the quant review. So the quantitative review identified biochemical variables and healthcare costs as unique outcome domains that weren't identified in the qual review. And I think I have, yeah, so there they are there. And in the qual review, there were a range of 9 outcome domains that were identified unique to the qualitative studies that weren't discussed or measured in the trials. So things like parent support, healthcare worker communications, healthcare professional knowledge and competence, normality, the normality of the infant, suffering, physical appearance, overall health state, vitality, and physiological stability. So the qualitative review, in reflecting on this process, we felt that the qualitative review added a depth of understanding to those biological health system domains, outcome domains that were identified in the trials. And that more outcome domains were identified than would have been identified by the quantitative review of trials alone. And they focused on factors that were beyond the infant's medical condition. So a more holistic view of the infant's growth and development and their relationship to their family and their bonding. So those kind of psychosocial factors that are so important in considering the whole infant, the whole family. And that these outcomes may be more visible to patients and parents and healthcare providers. They may be more recognizable because they resonate with the experience of these transdisciplinary members of a consensus development team. And, you know, anecdotally, that is what we found in our consensus development meetings, that the patients, former patients and parents and healthcare providers tended to understand these outcomes and identified with those, and were very happy to discuss those in more detail as they were presented in the consensus development meetings. So that was good. It stimulated more discussion in the consensus group meetings, and that addresses a particular need in consensus development methods, because often patients and members of the public often do not contribute as much in consensus development meetings in comparison to researchers and to trialists. So it's a way of stimulating that more full discussion that has that engagement of those key stakeholders. In terms of limitations, of course, there's limitations to this method. The qualitative review synthesized outcome domains that weren't originally intended to prioritize important outcomes. So I think only 3 of the 62 studies that we had actually asked participants directly what their priorities were. Most of the studies were asking parents, for example, or nurses, for example, what their experience was of caring for neonates in a NICU setting, or of being a parent of an infant in a NICU setting. And we took the view that if it was mentioned in a study like that, it must be considered an important outcome or an important issue. But we recognize that this remains a proxy for understanding more directly what is important to people. And again, because this was generated as a list of outcomes or issues for further discussion in a consensus development meeting, it was meant to inform that discussion and give a basis for those discussions to start to take place. Another potential limitation is that there was a necessary removal of broad concepts and a consolidation of similar concepts prior to deriving a final outcome list for consensus group consideration. So by that, we mean that we might have had articles that were talking about issues that were ultimately related to suffering, for example, about infant suffering and pain. And we needed to consolidate the data that arose from those different studies into categories that allowed us to derive a final outcome list. So, and that is why we had 2 reviewers undertake that analysis to make sure that we were being consistent in our thinking and being critical in our thinking. And of course, the study findings for the qualitative review were used without quality assessment. But again, as I mentioned, the intent of this was to generate a list of potential outcomes or issues for discussion and critical consideration in terms of the transferability and applicability by a consensus development group committee. So the critical consideration we were expecting to happen within the consensus development process, and it certainly did. In terms of future development, I think what we would like to see is to, or certainly what I would like to see is to compare this method of deriving outcome domains for consideration against primary qualitative research. So if we do a systematic review of qualitative research, how does that compare to actually doing primary qualitative research like focus groups or interviews with public stakeholders? Do they identify the same outcome domains or issues? What is the cost or resource for both of those to try and determine, and also what's the utility in the consensus development process in terms of the amount of discussion that's generated. And secondly, one of the things that happened between the quantitative review and the qualitative review is in the quantitative review, we did quality assessment of all of the included studies. But actually, all we were doing with that quantitative review was identifying a list of outcomes for discussion at the consensus development meetings. So if both of these are scoping reviews, why are we doing quality assessment? That's not normally a stage that's done in a scoping review. And so, it's just something to consider, and something that I certainly had a question about as we were going through the process. So, list of the processes, the references that were used around consensus development, and the paper from which this presentation was drawn as well. And that's it from me. So I thank you for your time and attention, and I look forward to questions because I'm sure you have lots. So thank you.